I have all kinds of alarms going off in this case because this is a really good presentation of early response and very deep response. So I think statistically, based on clinical trial data, this would be a really unusual outcome. So in backtracking, one might even want to inquire about adherence to therapy. Was there inadvertent avoidance or unknown to the practitioner that the patient might have been off therapy? Because this is a pretty clear case of resistance, as you said. And I'd up the ante and say that the bone marrow should have been done right at the time they walked in the door with the blood counts. I mean, you may have been saying that.
Correct.
Because 12% blasts could be an iceberg with much worse disease. I see how someone might have said, let's try another second generation TKI, but clearly more data could have been really helpful in this case.
That is correct. In fact, not this scenario, but we've seen patients who responded so well. They have a blast phase, but not CML. So they're Philadelphia negative.
Some other disease.
Other diseases going into AML, full AML, these are not transformations. And of course, as Mike alluded to, compliance is an issue here. It's very surprising to have somebody responding so well, losing this response in this way. Now, this woman was offered dasatinib, and then when we did the Sanger technique afterwards, we saw 359 mutation. We know with a second-gen TKI, there's higher prevalence of 359 because they suppress all other mutations. Therefore, I would have checked for mutation right away, and I will not go on to dasatinib. Even if there's no mutation, I would have chosen for this patient Ponatinib. They failed already second-gen TKI. The rotation of second-gen TKI, unless you have intolerance, doesn't give you good yield. This woman is almost blast phase, very close, very transforming. I would have chosen Ponatinib for this patient and not.
I'm going to ask you your own question. And what dose would you have started her on in that setting? Because, again, I agree that this is a very interesting and probably a good patient for Ponatinib. No known risk factors that we've been shared for in the history for cardiovascular or other vascular events. What dose would you have done knowing she's resistant to a second gen after 4 or 5 years of good response?
That's a great question. I don't have the perfect answer to it, but we know from the label the drug is approved at 45 milligrams per day with recommendation to reduce the dose as soon as you can. I would have done, if possible, NGS to see if I have a compound mutations more than 315I, documented or identified, because if I have a compound mutation, I want to go, of course, for 45 milligrams per day. If I have no mutation whatsoever, I would have chosen 30 milligrams per day and reduced to 15 once the CMR is obtained. Otherwise, for this patient with 359 mutation, I was 45 milligrams per day for a short period. As soon as I have a response, which it should be obtained within 3 months, reduce the dose and go for a lower dose.
You want to talk a little bit about the additional mutations that Dr. Jabbour wants to look for?
Sure. Well, you alluded to the fact that, just because you find one mutation doesn't necessarily mean it's the sole mutation that's present. And the whole issue of finding more than one compound mutations, sometimes in the same clone, sometimes in different clones, can be biologically relevant and obviously ultimately clinically relevant too. We've just been talking about BCR-ABL mutations, or more specifically Abelson mutations, but it sort of also opens a discussion perhaps about should we be doing mutational testing, looking at other genes and in CML, and there are emerging data there too that looking for mutations of ASXL1 or Icaros zinc finger or RUNX1, if that's what you're alluding to, are found in CML and appear to be clinically relevant too. So there's more, not that we didn't learn this, but there's more to CML than just BCR-ABL testing.
There's good data from Michael Doniger and Tim Hughes' team in Australia, where they look at patients who have mutation identified by Sanger technique, and then they give the appropriate TKIs based on a mutation profile, and they have myoclone that progressed on the road and lead to full resistance. And these what we call myoclones, they are equivalent to full clones later on. So why in somebody failing second-gen TKI, I would favor more Ponatinib than rotation of second-gen TKI. Unless I have true intolerance, pleural effusion, I would go to nilotinib or vice versa.
I like your answer to start with the standard dose and lower the dose, because for the person, because we can't settle the issue on what additional mutations and compound mutations exactly how to manage them. I think for the typical provider that might be looking at a case like this, and all of us, kind of just in the clinic, when we only have basic tools available, I think we got to use our best information. And clearly, we could have changed the outcome a little earlier in this case, but I think standard dosing and assuming the T315I could respond, I think we'll maybe hear how things go in a bit. But
and I think the key is, as was mentioned, regardless of kind of what dose we start at, is remembering to reduce the dose when patients have responded.